Welcome to the Strive podcast, where we embark on a captivating journey through the realms of mind, medicine, and motivation. I'm Simon Munham, your host, and today I'm honored to be joined by Dr. Russell Lonser, neurosurgeon, physician scientist, and one of the leading figures at the intersection of surgical innovation, translational research, and academic leadership. Currently serving as the chair of the Department of Neurological Surgery at The Ohio State University, Dr. Lonser has spent his career operating at the frontier of medicine, where clinical care, research, and ethical responsibility converge. He is internationally recognized for his groundbreaking work on von Hippel-Lindau disease, leading decades-long natural history studies that fundamentally changed how patients are monitored and treated worldwide. At the same time, he has been a pioneer in neurological gene therapy, helping integrate real-time imaging, surgery, and molecular medicine to restore function in devastating neurological disorders. In this episode, we trace Dr. Lonser's journey and the experiences that shaped how he thinks about risk and responsibility, explore the power of simplicity, examine how innovation can be scaled responsibly, and close with personal reflections. Don't forget to like, follow, and share this episode to keep up with the insightful conversations we bring. For more updates and exclusive content, follow us on Instagram or X at strive_podcasts and on TikTok at Simon Munham. Join our community and be part of the journey to explore mind, medicine, and motivation. Hi, Dr. Lonser.
Hi, how are you doing?
I'm doing well. Thank you so much for coming on the Strive podcast. I really appreciate you taking the time to do this with us and share your personal experience and journey throughout neurosurgery.
My pleasure. Thanks for having me.
Of course. Just to start off, could you take us back to the beginning? What moments or influences most shaped how you think about medicine and discovery?
I think, it's throughout the years, even growing up, and through college and med school and things like that, is really interacting and having a natural curiosity about learning about different things, particularly as it moved over time into the neurosciences, because there's a lot of opportunity, I think, there that was undiscovered at the end of the day. So it's just that kind of innate curiosity at the end of the day.
Definitely. And, as you were going through these different experiences and develop that curiosity, was there an early experience in your training that fundamentally changed how you viewed risk or responsibility as a physician?
I don't think there was one singular event. I think it was more a process of you learn as you're going along. You see a whole host of different things that occur during that training process. I trained at the University of Utah. It was a high volume center. With outstanding faculty and mentors there. And I think, it was that kind of being immersed in that process with outstanding mentors in an incredibly rich, innovative environment for training.
And you've been a pioneer in many different innovations within von Hippel-Lindau disease in various aspects of neurological gene therapy. At what point did you realize your career wouldn't just be about treating disease, but also redefining how we approach it and understand disease?
Yeah, that's a great question. And I think it was really, working again with mentors back at Utah where they were very innovative and looking to, fix bigger problems than just the singular patient. And then I think it was really Ed Oldfield when I did research time with him during residency and then started my career at the NIH. I was there well over a decade. And I think, but working with Ed and really seeing, that if you really get at the core principles of problems, whether it's understanding the biology, like a lot of that was directed toward VHL, or looking at innovative ways to treat diseases neurosurgically, and that probably leans more to the gene therapy. But Ed really kind of, through example, led the ideas of how those portfolios could work together and how a bigger goal is to really have impact across a wider swath of disease than the singular patient, which is absolutely critical, though, to how we treat patients in neurosurgery.
Definitely. And I find that quite interesting because we have these population level studies that can provide general, trends or descriptions about this group of patients as a whole. But then when you look at individually, on the individual level, patient to patient, there's also a lot of variation. So the work you've done is very cool, and not only asking simple questions, being able to generalize to that population, but also understanding patients at a fundamental level and asking questions from there to then extrapolate what we can about the population.
Yeah, exactly. You're exactly right.
And I wanted to talk about that a little more, the power of asking simple questions.
Yeah.
You said that simple yet profound questions drive real impact. How do you recognize when a question can be deceptively simple versus merely shallow?
Yeah, that's a really good question. I think, that comes along with experience at some level and understanding, I think as you get more and more comfortable, and you use the example of neurosurgery, as you go through more and more neurosurgery through training, and then you develop your own personal experiences when you're done, your level of understanding continues to grow. And that's when you can form probably better questions, but by no means do I think you need to be years and years out. I think you will form some really important questions as you watch, how patients are managed and what patients do and what disease processes do during training. I think very early in your career, that's when when that innate curiosity and we are still learning a whole bunch really drives you to ask those fundamental questions and not make them too complex. It's really just sticking with very simple concepts. I mean, that's where probably the most profound, discoveries have been made. Anything overly complex tends to really fade out very rapidly.
Definitely. And that ability to discern, that judgment, can that be something that's taught, or do you think it's something that only emerges through lived experience as you go through training, as you can feel that emotional burden placed on you with dealing with these very devastating diseases at times, and the insight you gain afterward? Is that discernment coming from there, or is that something we can also teach?
Yeah, I think it's both. And I think more than anything, for me, it was examples, having great mentors, including Ed Oldfield, where I watched how they approached patients and how they approached questions to investigate disorders and how to begin to, hypothesize how to improve them. So I think you're taught by example. You can also be taught somewhat, but I also think you have to have that innate curiosity. Not everyone is going to look at the same patient in the same way and say, okay, what are things I could do better in understanding this disease? I don't think there's a lot of physicians that don't do it. It's not necessary. They can be outstanding physicians. But I think, for me personally, I think for many neurosurgeons, there's an intellectual curiosity that propels the field forward. And that's been historical in neurosurgery. I would argue neurosurgery has been one of the most impactful fields across a whole set of different specialties because of things we've done, from electrocautery to understanding the biology of tumors. That many of those ideas have been taken into other fields and accelerated them, despite neurosurgery being a very small field.
Definitely, a lot of innovations trickle down from neurosurgery, and that's very, very cool to think about, looking back 100 years and stuff. One of the innovative findings, discoveries that you've done has been your work around VHL disease, von Hippel-Lindau disease, and your Lancet work on VHL disease reshaped management worldwide. What do you think was that single core question that really unlocked the entire body of work that has become what it is today?
Yeah, that's a great question. I don't know if I've been asked that before, but it was the simple question: how do these tumors behave? Like, what is the natural history of these tumors? That's all it was. We just watched these tumors. And we operate on patients, obviously, with early symptoms, but we knew many of these patients had hundreds of tumors. And the simple question is, if we can understand the natural history of these tumors, then we can better treat them with the tools we have available at the time, that being surgery. Many diseases, if not the vast majority of the diseases that we treat, not just in neurosurgery, other areas, we don't understand purely the natural history of them. We have a sense of them because many times we're intervening as we need to for therapies and things like that. But it was just a simple question: what do these tumors do? And that's all it was. And then we extrapolated that to other areas like NF1, NF2, things like that. But this was just being to do that is just being very defined. We just follow these patients at defined intervals with simple, clinically available in important studies like MRI, and tracked it that way, and were very religious about how we recorded that data and did it very systematically. But again, just the simplest question, what do these tumors do in that disease?
That makes a lot of sense. And especially with, all these bells and whistles that we have with omics or AI or high dimensional data, I think just having those fundamental core questions being scientifically sound and, driven by that curiosity and intellectual clarity that you're talking about, opens up a whole host of innovations.
Yeah, 100% it does. It's one of those things, like, now that we understand the natural history of the disease, we also know now that we can see the impact of things like new chemotherapeutics that come on, because all these tumors will exhibit a saltatory pattern in which they don't grow for sometimes years, but then can regrow. But we didn't know how to manage it. Does that mean the chemotherapeutic or radiation was a success because the tumor didn't progress? Well, maybe it was, maybe it wasn't. In many cases, it wasn't. But just understanding that gave us a lot of insight in how we can now test out new therapies, prove their efficacy or lack thereof. But it was important to understand that it also gave us a better sense of how do we manage these surgically? When do we intervene? It also let us understand something that we were surprised by, but after the age of 40, the rate of new tumor formation goes down dramatically. So that opened up a whole new host of biologic questions that we had to answer as well from a simple imaging follow-up study.
And your VHL natural history studies followed these patients for decades. Did following them longitudinally change how you think about intervention, restraint, and timing in neurosurgery?
So the way we started off with a policy of not operating unless the patient had very early symptoms and not operating off of growth. We didn't understand the growth patterns even when I was a fellow in the late 90s and early 2000s, but we knew that there were so many of these tumors in some of these patients that unnecessary surgery could, impact that. So what we did, we started with that philosophy, and that was controversial at the time. Nevertheless, the data showed that we didn't need to operate on imaging changes. And in fact, patients would undergo, with a span of, in 10 years, 4 unnecessary surgeries on average. So it taught us that very early on that, we needed how to manage those patients based on these growth patterns and things like that. It also taught us that we learned later on, as we were looking at the development of new tumors or progression, that after the age of 40, that drops off dramatically. And if we could minimize the number of surgeries in those patients, and we could preserve function. We haven't published this data yet, later learned that with very judicious surgery, we can maintain function in the vast majority of patients. Suggesting, and with that, the life expectancy has neared near normal levels with that type of approach. So it taught us a lot very early on. And there's a lot of other biologic things we picked up just by distribution of tumors and things like that. Just, beginning to really understand the characteristics, as you mentioned earlier, not just in a singular patient, but that's when we pulled data across patients, and it really became profound.
Very cool. And it's very cool from like a student's perspective too, because when we learn about things, especially when we do research, it almost feels like it's in a snippet of time, right? Because that's like the only time we're allotted with, med school and, the limited time we have. But being able to see a study through for that long and being able to, reap the benefits of that study to apply to new patient populations is quite fascinating.
Yeah. No, and it's been probably, one of the most rewarding things to do, from a personal perspective in a career. And when you start these things, like you said, everything is in a snippet at some level until you really launch into your career. And then I remember when we first started that study, 25 years ago, I thought, oh my God, this is going to go on forever. How can this be sustained? And, sure enough, 5 years goes by, 10 years goes by, 15 years, and it's accruing data, and, each of those time points provide deeper and more important insights that, really make that journey enjoyable. But it's also keeping other things going, because there are gaps in time when you're not, reanalyzing data from year to year, and you're really going from, sometimes 5 years to decades, and change.
Definitely. And to talk about that a little bit more, on a personal level, what does that kind of work demand emotionally that the short-term studies might never reveal?
It's remaining steadfast in doing those things year after year after year, being willing to evaluate and reassess how you continue to do that trial. Maybe initially it was every 6 months those patients got imaged. After 7-8 years, we realized we didn't need to do it, but we had accrued enough data, back to your early question, to know that we didn't need to. We also accrued enough data over longer periods of time to understand that the imaging sequence or cadence was probably too frequent to have therapeutic importance, at least with the craniospinal hemangioblastomas and things like that. So yeah, I think it's really remaining, convicted to doing those trials, to adapting. But I think saying that, there's only those can go on for a long period of time. You have to have other intellectual outputs, shorter in time frame than that.
To have many battles won along the way as you go for like the longer.
And make sure you have that you're not waiting 5 years every time you're reanalyzing the data and coming to new conclusions or supporting previous conclusions.
Definitely. And it's actually quite interesting from my perspective too. As we go through medical school, we learn about von Hippel-Lindau disease, the NF1, NF2 relationships, like the hemangioblastomas that happen as a result. And the endocrine to neurosurgery connection is quite interesting to me, because Cushing's disease too, a lot of people don't realize it's named after Dr. Harvey Cushing. Yeah. And it's an endocrine disorder, VHL disease too. It's an endocrine related disorder, but there's a lot of neurologic manifestations. And so even though neurosurgery is, neurological surgery is surgery of the nervous system, there's a lot of medically related components that I find so fascinating.
Well,
the field.
I don't know if you knew, Lindau, von Hippel-Lindau worked with Percival Bailey and Harvey Cushing. He was here on a scholarship from Europe. He was at the Karolinska, and here on scholarship from Europe, and worked with Cushing. So Cushing and Bailey thought that the disease should be named after Lindau, not von Hippel, because von Hippel was an ophthalmologist who saw retinal hemangioblastoma but didn't link the other tumors in that patient to a broader disease. It was really Lindau as pathologist that did that, but worked with Cushing and Bailey. So a lot of these things tie back to neurosurgery.
I also wanted to talk about gene therapy in real time. I find that whole field fascinating as well, watching gene therapy distribute in real time via MRI. It's a very extraordinary, almost sci-fi-esque procedure for radiologists and surgeons. What do you think the cognitive skills, or what new cognitive skills are required when imaging becomes dynamic rather than static? Yeah,
that's an incredible question. And I think what that is, and I'll liken it to when I was in training, all we did was open vascular neurosurgery. Then endovascular was emerging as I was finishing up. And it probably is along the same lines. Surgeons can do well with any kind of three-dimensional type of thing, even from open belly surgery to laparoscopy. Surgeons that do the open well, people have said it, do laparoscopy well. Same thing, I think, with open vascular to endovascular. Some of these things come together. So I think that, what we're seeing with this is a new paradigm for neurosurgery. I think it's this idea of now, instead of seeing it directly in front of you, you're seeing it in real time on an image, and you're adapting to that, and you're seeing by changing flow, by repositioning or positioning cannulas, that you can create different types of things, and we call it painting the structure that we're trying to perfuse, whether it's the putamen for Parkinson's disease, midbrain structures for AADC deficiency, the thalamus for frontotemporal dementia. We can apply these things, but it also becomes far more biologic than what we've done in the past. As surgeons, we've typically, it's rare we augment things. Most of the time we're removing things, and it's purely based on anatomy. Now it's anatomy and biology, because when we're doing the gene therapy infusions, that infusion's based on not just anatomic perfusion, it's based on understanding the interconnection. So I'll give you an example of frontotemporal dementia. We can use the thalamus as a site through thalamocortical projections, because when we place the vector with the gene, that gene expression is carried through those connections. So in theory, we could potentially treat parts of the thalamus and have differential effects or specific effects on different cortical areas. And we do the same thing with the putamen, treating circuits, Alzheimer's disease, the entorhinal cortex, part of the limbic system. We use those circuits because we can now treat from a single source the circuits. So a long-winded way of saying now the anatomy is still absolutely critical, but we're now seeing the anatomy on image rather than open. But we're also having to understand the circuitry surrounding the what I'll call nodes within that disease circuit.
Definitely. And this area itself, right, as you keep opening it up, it almost fades between different subspecialties of neurosurgery. Yeah. And I find that fascinating too, because when we say functional neurosurgery, right, there's different areas of function that are preserved through different practices of that. But I feel like different subspecialties in neurosurgery already do that. And with these intra-arterial therapies and going endovascularly, it opens up like another realm of function preserving. And so how do you see this playing out as like the neurosurgeon's role evolves, right? How do you integrate this?
I think that was really insightful what you just said, because I think every time neurosurgery has grown and expanded or evolved new technologies or ways to treat, more and more specialties have been involved. And that's, you can look at spine, you can, where we have, we work in broader teams, but we also work with orthopedic spine surgeons. We work with broader pain groups for, failed back syndrome and things like that, and anesthesiology, pain specialists in that area, neurosurgeons doing that. Vascular is the other example, obviously, where radiologists and, originally cardiologists and, neurologists are doing it. So I think, this is one of those intersections where those types of things, will occur as things become less invasive, doors open to other specialties. In its current state right now, this is truly a neurosurgical process, and it will remain that probably for a number of years, but it will bring broader groups together. We work even more tightly with neurology as we're trying to sort these biologic gene therapies out. We work with groups, that we never would have imagined in aging and things like that. So it broadens the multidisciplinary effort across these disorders.
And it's quite cool because we can have coordinated care across different aspects of the patient's, life cycle. I'm using my business lingo right now, but within the hospital, being able to have different integrated care pathways is quite useful from a patient perspective.
Yeah, 100%.
Definitely. And as someone overseeing the world's largest neurological gene therapy program, what surprised you most about translating this lab science into actual clinical care?
That's a great question. I would say we're now thinking about how do we scale these technologies, these techniques up. And at first, when you start, you're excited because we gained insights 10 and 15 years ago about how we can use vectors and gene therapy to do it. We were working in parallel, refining the delivery techniques, refining the ability to image, confirming that. And then we got to the point where our group and other groups have seen some successes, early successes that potentially could lead to transformative therapies across disorders we would not think of typically neurosurgery. But then we had to start thinking about it in a broader term. How can this be used universally? And how do we make sure that these technologies or these treatments are available worldwide? How do we scale them up in the most effective, efficient way? Is it the same type of imaging? Do we need imaging, in 5 years or 10 years? That was the part that was most surprising, is where you get past all the excitement and start to see some of the impact. Now, if this impact is to carry through and become a true therapy, how do we make sure that everybody can have access to it? How do we make sure, because you're not trained as a neurosurgeon currently to do these, how do we make sure that neurosurgeons are able to do these? Because it's a surgical issue. So I think that was the thing that was probably most surprising to me at the end of the day.
And scaling is quite difficult because we have these pockets of I think the U.S. as a whole is like probably the leader in healthcare innovation, and bringing these technologies at the forefront, and pushing the boundary of what is possible, but then figuring out how to trickle that down so that every individual gets it is quite difficult. And you predicted that gene therapies would be close to widely available within the next few years to 5 years. What has to change, do you think, within healthcare systems, or within modern healthcare tech as an industry, for that to be true?
Yeah, that's as you know, is a super complex question. So you can have the pharmaceutical, what we'll call the pharmaceutical side, which is the gene. How do you make sure that companies that are developing these things, and we've all heard this, make sure that they recoup the massive cost of going through clinical trials and things like that, allows the innovations to still occur. I think that's probably the one thing we'll see. Insurance companies is a second piece of that. How do we, as surgeons, make sure that there's reimbursement for these things? There's a lot of, not just in neurosurgery across, where the reimbursement doesn't match the amount of time and complexity that goes into. So we're working on all these things. We have to make sure that happens. We have to make sure that the field evolves, just as endovascular did, radiosurgery, all these things evolve. And then how do we do things that be outside of the training, making sure people are trained for that, to do these things, and how do we make sure that the infrastructure is widely available, and that these can be done in a rapid, and these are truly minimally invasive. And so all of these things now in parallel we're working on, but those are the complexities. So it hits at it's not just unique to this gene therapy. It's unique to, it's present in all areas, to be honest with you.
Definitely. And it's something that we should also focus on as on the provider side, because as I go through business school, I'm seeing how it's a multifaceted, very complex system at play. But medical school doesn't really train us for understanding reimbursement, or how the payer-provider relationship works, and how innovation, how funding for that works, or the process of getting medical device development certified by the FDA, all of that. But it's very vital to pushing that boundary forward, and innovating, especially in a field like neurosurgery that's rapidly changing. I think having that background has made me realize that many problems we see in healthcare are much more complex and very multifaceted than we think about.
Yeah, and I don't think you're way ahead of your years in looking at it that way, because I never was trained that way, or educated in that in med school or in training, and it wasn't to this day. There's very little of it. We are integrating it with our residents, quite frankly, now, because I think, NIH, I spent 13 years there. NIH is an incredible place. I think the idea that those dollars will continue to expand, or minimum not be contracted, is probably not realistic, and that's fine. But I think what that will drive us to do, not just in neurosurgery, across medicine, is to really form collaborations and partnerships with industry partners, as well as foundational sources. NIH will remain critical as well. But I think to really advance at a rapid pace, we need to explore some of these other areas. But that was something, that was considered taboo at worst when I was in training. You kind of did your NIH funding, you got it set up, you developed your molecule or whatever you wanted to use, or your piece of equipment. You took that from bench to bedside. On average, we know these numbers, about 13 and a half years. So you had one or two shots at goal during your career, versus I think we have an opportunity to do things at a much faster pace than before. But we've got to get rid of the old ideas of there's one singular path to do this. And so, but you're right. This is not an inherent thing you learn in med school, or you have a business background, business career. Unless you have that, you don't inherently know it. And even with an MBA, you still don't understand it until you get out there. You're working in the field, you're seeing what a clinical practice is like, you're developing something. Very few places are you taught, well, here I got this device, now how do I get an IDE? How do I get an IND for this drug? How long is that going to take? How do I interface with the FDA? And those are all things you learn on the, just by experiencing a lot at this point in time, at least.
Yeah, and drawing back to what you said about being able to discern, have that ability to, have precise judgment, right? I think the training itself is one aspect. I see a lot of colleagues, this is probably a conversation for some other time, but I see colleagues doing the MD, MBA, and then just, not doing residency, going into industry. But you have to also have that lived experience and go through, those patient interactions and be a part of the system to really understand where the stressors are in the system in order to innovate, right? That's just my perspective on it.
No, I think you're 100% right. So you can take those two paths that you just described. One is you learn a tremendous amount about human anatomy, physiology, pathobiology, and you have the MBA, and then you go off into business because you have an incredible wealth of knowledge about at high level how the medical system works, but how human interaction works, and it's an incredible resource to the business side of it. What that doesn't allow for is if you go through the traditional path where you get the MBA and MD, and then you go out, you do your training, you go into whatever field you go into, and then you innovate in that field. That's the piece that you get for the additional training. And for me, that's probably the most rewarding piece, is you will fail multiple times and go down a variety of different paths. But it's like corny saying, it's a journey. It truly is the journey, because during that journey, you're waking up every day excited to go to work, because you can have impact on something that could potentially change the lives of millions of people. I think you lose that in the former pathway of leaving, but doesn't mean that it's a wrong pathway for anyone at the end of the day. It's just a different pathway.
Right. And it's nice also being undifferentiated from, at this stage at least, because I can fail first and fail fast, right? I have that bandwidth to do so. And then it also gives me that different perspective to approach my training as I go through the years.
Yep, 100%. These first few years, and I'll tell our junior faculty, the first 3 years of their career, as you said, you have the ability to fail and recover very quickly. You're going to ultimately differentiate into research pathways and clinical pathways over time. And that's really truly based on your expertise, and where your impact, rather than moving from thing to thing without a sustained pathway over decades, will also mitigate some of the impact that you could have. This is a time, medical school, residency, first several years of your career, those are some of the most exciting times of your life.
Definitely. I'm looking forward to it. And talking about your leadership as, with your position as the chair of the department at the Ohio State University, what surprised you most about leadership that no one really prepares physicians for?
It's really about making sure that you have culture. The culture, that saying, culture eats strategy for breakfast. And it really is culture. And what culture is making sure people feel valued in their roles and what they're doing, making sure that when you build a program out, that individuals have different strengths, that those strengths are preserved, exploited, and that they interface together, that you don't create competing environments of successful people, because that's demoralizing at some point, even because you have two wildly successful people that spend more time competing than they do actually building those things. So I think, having an environment of collegiality, consensus, and really with that program having programmatic objectives, because I think while you can have all those things in place, everybody needs to know where we're going in 5 years, where we're going in 10 years. What is our ultimate goal? Because you can get lost in the noise very easily when you're in the operating room, going to clinic. It just becomes very mundane at that point. I think it's building a culture and setting, very lofty goals and expectations for the program, having people buy into it.
Definitely the power in numbers. I truly believe in that. If we can, I see it in like, I listen to like the Jocko Willing podcast, and like having an Army or Navy SEALs where that you have to perform at like the highest level, and having that shared vision or goal, and being able to trickle that culture down really creates like dividends down the line, and being able to innovate or just like the output from
Yeah.
a group as a whole than what can be done as an individual. So definitely.
Yeah. If you're going to work to take care, and it's one of the loftiest goals in the world to take care of patients, and it has to be your North Star at the end of the day, that's all fine and good. But at some point, very early on, we all become expert at the area we work in. And I think without that ability to see beyond that, it really becomes a 9-to-5 job. And you can say, well, that's great, right? You're doing the same things, you get reproducible results, you get good results, things like that. But I think, at least for me and for many neurosurgeons in particular, you have to have that idea, because all our lives, the work hours, setting goals throughout your life for doing these things, it selects us, a type of person that wants to do that. And I think, for me, I would be very bored going to work, operating on tumor patients every day, going and seeing the same patients in clinic, without some idea that maybe we could change how these patients are treated. Can we do something different and better? But if I was just doing that, in a hospital employed practice, which is, those are wonderful, but I think I would be crazy, within the first 5 years of my as an attending. So
Definitely. And I think academic medicine is able to provide that sense of flexibility, but also hope and wonder for what can be done within medicine, which I find fascinating. But we also talked about, that having that some places have like competition or this. And I think that some of it might stem from like an imbalance of incentives, at least from like the different stakeholder sides, right? Like if they like physicians within like the group or whatever. And I've found that to be quite interesting and quite applicable outside too, whether it's imbalance of incentives between payer provider, imbalance between industry, health system, insurance company, health system. And so I was wondering if you could redesign academic medicine's incentive structure, at least one component of it, what would you change first?
yeah, that's the impossible question that, but it's a good question. It's a great question. I don't know what I would do, because a lot of this, we were just talking about this at one of our faculty meetings, is at the end of the day, we all have to be responsible to ourselves. And there's no perfect guardrail system to not allow incentives to drive an individual one direction or the next in excess at the end, whether it's financial for, volume, whether it's academic to, for publication or things like that. There will be these different incentives will drive people in different directions. And at some point, you have to decide who you really are, what you want to do. Well, you can set up rules to minimize or mitigate some incentives. You're then at the same time accentuating other incentives that may be in conflict. I'll give you a more concrete example. If you're trying to drive access, which is critical to patient care, whether you're in academics or whatever, productivity incentives are great to do that. Access incentives are great to do that. But you could argue to me, well, then what would happen if that becomes a major driver? Then those individuals will go into having, academics could drift away from that, and you really become, just operative, high volume center, which is great for patient access and care potentially. But what that does is it mitigates the academics. So if you over incentivize then the academics to drive, then productivity and access decline. So at some point, and we were talking earlier about, culture and portfolio, you will have some surgeons that will be high volume, world-class, surgeons, have academics that are world-class surgeons, but will really be driven intrinsically to do the research pieces, whereas the high volume surgeons may be driven more for a teaching and mentoring type role. So, we look at this we look at ourselves as a large portfolio of looking, having all these puzzle pieces fit together. But my job as chair is to really make sure that those incentives don't get out of line with reality and optimal, progress toward goals of, world-class healthcare, world-class research, world-class training, because, you hit the nail on the head. Incentives can drive these things, and especially in medicine, you're going to get pulled in 10 different directions.
Definitely. And that's something I think about too, with like, as I go through my career, what kind of physician do I want to be? What kind of problems do I want to solve? Because ideally you want to fix everything, like all of the problems in the world, right? But realistically, there's only 24 hours in a day. So dedicating your time and energy to a select few things that you build your brand around or your work around, I think is what probably would lead to the highest impact, at least within those disciplines.
Yeah. And it's hard, I think, at times, you're 100% right. Some of the harder paths, the most rewarding paths, I think, for a lot of people are the hardest path. It's easy to get distracted early on when these incentives are put into place. So you come out, you want to be the best surgeon, in your hospital, in your system. You spend a lot of time doing that. You get a lot of credit for doing that. The referral people love you. You're available all the time. And suddenly 5 years goes by and you spend all the time doing that. And you still be an outstanding, excellent, world-class surgeon. But even that incentive alone, whether it has no monetary tie to it, but that, building those referral practices, which is incredibly rewarding and it's instantaneous at some level or very, very short term, to do. Those things can, take you away from a longer term goal, as you were mentioning earlier. If you want to really change disease, that's a very different path. It's a much harder path.
And I wanted to transition a little bit talking about meaning, identity, and the weight of responsibility. You spent a career operating at the edge of what's possible, making decisions that carried immense weight and consequence. How has that shaped who you are as a person, not just as a surgeon?
Yeah, that's a great question. I think, when you bring up cases like that, it's, if you look at VHL, it's, routinely starting to do brainstem tumors. And prior to that, morbidity mortality rates were high, from the previous publications. And then learning, systematically moving that direction, which is high risk. I think doing some of the early infusions in brainstem and things like that 20 years ago, those were, where you're really looking kind of into that abyss. And if things don't go right, there's no way you can walk away from that, without responsibility for it. I think what that did early on and it was bolstered by having Ed as a mentor and as a boss at Oldfield. There's a lot of security at that, but having to make those decisions as a very young faculty at the time really reshaped how I think about, taking justified risk, to build programs. Like, we really invested in earnest about 7-8 years ago in gene therapy when it, wasn't as popular as it is today across a bunch of different platforms. But there's risk with that. But I think those early experiences made me very comfortable with taking those types of risks. But in always, it has to be balanced with understanding. But at some point, you will have to make that leap and say, okay, I've de-risked everything I possibly can. I've got as much understanding, because it was very easy for you to talk yourself into never moving forward and being happy with just, okay, well, we can get another bit of information, but it's going to just take 5 more years. And yes, many times that is prudent, but that's where taking those risks early on really shapes what you do when you want to build a program and things like that.
Definitely, and it has amounted to what the portfolio of what you've done now is, which is amazing, right? But starting out earlier, it might have been very stressful emotionally, trying to navigate, an untreaded path. And for medical students and residents who want to innovate but are afraid of making mistakes, like you said, what do you wish someone had told you earlier in your career?
I think they told me that was great. I mean, I had great mentors in training that were innovators. Ron Affelbaum. I mean, all the instrumentation in the spine that he was instrumental in developing. Peter Heilbrunn was the chair. His work with stereotaxis and and things like that, navigation. Being around in an environment enriched like that and seeing, they had these pathways and they could talk about the fears or concerns they had. Ed Oldfield, with all of the different things he was, involved with, from Chiari malformation to convective delivery to spinal AV fistulas and AVMs, and looking at that and moving the field forward. But seeing those individuals, watching them and being able to talk to them, because it's those shared experiences, that allow you to be more comfortable, and also have them, people like that, that are sounding boards to say, hey, am I crazy for doing this now? Is this the time to make the jump? And so just having that and and the ability of people around you to help you with those, that's probably the most critical piece.
Definitely. And I myself, in my personal, professional career, I'm only grateful for all the opportunities that were given to me, and like I'm the result of, the people who have paved that path before me, and being able to get their guidance on, the different steps I take in life to have had immense benefit and fruits for me as well. So
yeah,
I relate to that. And as we come to the close of this episode, if you could leave one piece of advice for the next generation of neurosurgeons shaping the future of medicine, what would it be?
It really go out, find what you love. Also understand that opportunity has to be there. And many times if you have great opportunity, just from the innovative or, ability to have deep inquiry into something, that can really shape passion at the end of the day. But pursue it. Don't be afraid to take risks, and do it early, because if you don't do it early, it's something you're not going to be comfortable with later on in life.
Well, Dr. Lonser, thank you so much for taking the time to speak with me today. It was very insightful. I'm going to come back to this episode multiple times and, reflect on it, think about it, gain some insights as I move through my life and career. But thank you for taking the time, and thanks for coming on the Strive podcast.
Thanks so much.